Good day, everyone. The topic that we're going to discuss under colon 1 is colonic obstruction and lower gastrointestinal bleeding. Here are the learning objectives of this session. We suspect a patient might have an intestinal obstruction if he manifests the following clinical manifestations, namely abdominal pain, nausea and vomiting, abdominal distension, constipation, and obstipation. These are the so-called cardinal signs of intestinal obstruction. This slide shows the etiologies causing the obstruction in the affected bowel. In small bowel obstructions, adhesions ranks the majority of cases, which is attributed mostly to post-operative adhesions. This is followed by neoplasms, hernias, and other etiologies. For colonic or large bowel obstruction, the majority of which are neoplastic in origin or secondary to malignancy, and this is followed by volvulus, diverticular disease, and others. This schematic diagram illustrates the causes of intestinal obstruction by location, namely, number 1, the intraluminal, where obstruction is caused by the contents within the intestinal lumen, such as foreign bodies, gallstones, fecal impactions, or bezoars. Number 2 is extraluminal, where the obstruction is secondary to factors or conditions outside the intestine that causes compression to the intestine, such as adhesions, hernias, volvulus, extrinsic tumors such as ovarian and pelvic masses. And number 3, intraluminal, where conditions within the intestinal wall that leads to obstruction, such as tumors, strictures, Crohn's disease, or congenital abnormalities, ischemia, and other anastomotic strictures. This classification helps in understanding the underlying pathology and guiding the appropriate management. This slide enumerates the possible etiologies of intestinal obstruction based on the location of the pathology as we have previously mentioned. The diagnosis of an intestinal obstruction starts with a clinical history of having abdominal pain, abdominal distension, nausea, vomiting, and obstipation, plus a physical examination which may or may not reveal a scar from a previous abdominal surgery. With this, a diagnosis of intestinal obstruction is suspected. Then we do an abdominal imaging, and if with radiologic findings, the diagnosis of intestinal obstruction is confirmed. We request for an abdominal imaging, either an abdominal x-ray or a CT scan, is because we want to know important informations that the imaging modality can reveal. This answers important questions which are critical among patients with suspected intestinal obstruction, namely, number 1, is there an obstruction? Number 2, what is the level of the obstruction? Meaning, is it affecting the small bowel or large bowel? Number 3, what is the etiology of the obstruction? And lastly, what is the extent of the disease? Obviously, abdominal CT scan has a higher accuracy in providing answers to these questions over that of the abdominal x-ray. But still, abdominal x-ray is still an important diagnostic imaging to diagnose intestinal obstruction. There are some terminologies that you should all be familiarized with in intestinal obstruction, namely incomplete or partial gut obstruction, complete bowel obstruction, uncomplicated intestinal obstruction, and complicated intestinal obstruction. To illustrate what happens to the bowel in intestinal obstruction, the proximal bowel segment, which is the affected portion of the intestine above or proximal to the point of obstruction, is characterized as dilated due to the accumulation of the intestinal fluids and swallowed air that cannot pass beyond the point of obstruction. Thus, this accumulated intestinal fluid flows back antegrade up to the stomach, thus comes out as a bilous or greenish vomitus. The distal intestinal segment is the segment after the point of obstruction and is characterized as collapse due to the absence of intestinal contents. Incomplete or partial gut obstruction is a condition where the intestinal lumen is partially blocked, allowing some passage of intestinal contents beyond the point of obstruction. Thus, patient claims to still be able to pass out flatus or BM, and on X-ray demonstrates air appearing as black or lucency on the area of the rectosigmoid, which is the most distal part of the gastrointestinal tract that can be visualized on X-ray. This condition may progress to a complete obstruction, thus requires close monitoring and timely intervention to avoid complications. Complete bowel obstruction is a condition where the intestinal lumen is fully blocked, preventing the passage of intestinal contents. These patients claims to have absence of flatus and stool, and radiographic imaging fails to demonstrate air in the rectosigmoid area. This condition is a surgical emergency because of the high risk of bowel strangulation, ischemia, perforation, and peritonitis. Complicated obstruction is intestinal obstruction associated with complications such as ischemia, strangulation, gangrene, and perforation. As the luminal pressure increases in the proximal bowel segment brought about by the accumulation of intestinal contents that fails to move forward beyond the point of obstruction, the pressure increase compresses the vascular channels within the intestinal wall, namely the lymphatics, venous, and arterioles. This results to tissue ischemia at the proximal dilated bowel segment, leading to strangulation, gangrene, and perforation with eventual peritonitis. To better understand and interpret an abdominal X-ray, a basic review of the anatomical portions of the small and large bowel is important. The small intestines are located centrally within the abdomen in a supine patient. The ascending and descending colon are fixed in the periphery of the right and left of the abdominal X-ray film, as they are fixed to the retroperitoneum. The transverse colon is mostly located in the upper peripheral portion but can be lowered in position within the abdomen depending on how long and redundant it is. Same so with the sigmoid colon, which is in the left lower quadrant area of the abdomen. An abdominal X-ray is composed of two views, the upright and the supine view. The upright view is taken while the patient is standing, thus capitalizing on the effect of gravity. In an upright position, gravity causes gas to rise above the fluid within the dilated bowel. This separation creates the distinct air fluid levels. Also, the dilated loops stack on top of each other vertically due to gravity creates a characteristic stepladder appearance on the upright view. Chest X-rays are also requested as part of the evaluation of the pulmonary status for any evidences that may demonstrate the presence of pneumonia or pleural effusions that increases the risk to patients with intestinal obstruction. Also, this may be able to identify the signs of pneumoperitoneum as pointed by the red arrow, which appears as a lucency or blackish radiographic appearance below the diaphragm. In an obstructed patient, This signifies an intestinal perforation, which is a dreaded complication of intestinal obstruction. In a normal individual, the abdominal X-ray findings should not demonstrate or do not visualize any small intestines. Only colonic with fecal and gas contents can be seen. To differentiate small bowel obstruction from the large bowel obstruction, we interpret the supine view of the abdominal X-ray. The radiologic signs specific for a small bowel obstruction are: number 1, it is central in location; number 2, the dilatation is 3 centimeters in diameter; and number 3, the identification of the valvula conniventes, which are thin, closely spaced lines across the width or diameter of the dilated bowel, as noted by the yellow arrows. This X-ray film, taken in the supine, highlights the radiologic signs specific for small intestinal obstruction. Colonic obstruction in the supine view of the abdominal X-ray will demonstrate: number 1, a dilated bowel 6 centimeters in diameter located within the periphery. Also, a white line can also be identified, which runs only a third or half of the bowel width and not the entire diameter, typical in the small intestinal obstruction, the valvula conniventes or plica circularis. This partially transverse white line represents the haustra spanning only a part of the colon. CT scan of the abdomen is the gold standard for detecting intestinal obstruction. They are highly accurate in diagnosing this condition. With this, it can give us the information we would like to know, such as: number 1, the level, site, and cause of the obstruction; number 2, it can identify complications such as strangulation, ischemia, or perforation; and it can differentiate a small bowel obstruction and large bowel obstruction. Various views are reconstructed by the built-in software to optimize the visualization, namely the axial or transverse view, the frontal or coronal view, and the sagittal view. This slide shows the appearance of a sigmoid colon cancer obstruction as it appears on abdominal X-ray on the left, showing the abrupt tapering of the proximal dilated descending colon, which highlights the transition point or the site of obstruction. In your right is the CT scan images reconstructed in the frontal coronal view, which clearly demonstrates the hyperdense structure at the site of the distal sigmoid, which is the site of the colonic obstruction. Colonic obstruction or large bowel obstruction, or we can use the term malignant bowel obstruction interchangeably, as the majority of causes of colonic obstruction is malignancy. This type of obstruction is characterized by dilated bowels with large fecal loading, leading to bacterial overgrowth, which will put the colon at risk for possible impairment of the blood supply, leading to ischemia and strangulation. The colonic distension, as shown here, is brought about by gas coming from the swallowed air and as a byproduct from the bacterial fermentation plus the stool and liquid. The pathophysiology of a complicated colonic distension resulting to strangulation, necrosis, and perforation brought about by the compression of the vascular channels within the colonic wall is influenced by the competency of the ileocecal valve. A competent or a functioning ileocecal valve prevents the backflow of colonic contents back into the small intestine. Thus, this increases the risk for colonic strangulation because of failure to decompress the colonic contents back into the ileum. Thus, in colonic obstruction, there will be two possible scenarios. dependent on the function of the ileocecal valve, namely a competent or a functioning ileocecal valve versus an incompetent or non-functioning ileocecal valve. This condition is clearly depicted by this slide where both scenarios A and B, where both are the obstructing sigmoid cancer. In scenario A, has a markedly dilated descending, transverse, and ascending colon, but a non-distended small intestine. This is brought about by a competent or a functioning ileocecal valve preventing the backflow of the colonic luminal contents into the small intestine. However, in scenario B, the distension of the proximal colon is not as distended with scenario A and with small intestinal dilatation, which is brought about by an incompetent or non-functioning ileocecal valve. This slide shows an obstructing sigmoid cancer with a competent ileocecal valve. This is a typical example of a closed-loop large bowel obstruction where the risk for strangulation, necrosis, and perforation is high. Thus, once diagnosed, this patient would need an emergency surgery ASAP. In colonic obstruction, the cecum has the highest risk of ischemia, strangulation, necrosis, and perforation, regardless on where the location of the obstruction in the colon is located. Occurrence of cecal perforation or cecal blowout may actually be made faster by a competent or a functioning ileocecal valve. This is explained by the law of Laplace, where the cecum having the largest diameter experiences the largest pressure compressing the bowel wall. This X-ray demonstrates an obstructing sigmoid cancer with an incompetent or a non-functioning ileocecal valve, as small intestinal dilatation is evident. Patients with a suspected large bowel obstruction warrants a thorough assessment and timely management. Diligent history and physical examination with plain abdominal X-ray films confirms the diagnosis, followed by resuscitation with fluids, as most patients present with signs of dehydration as a result of vomiting and third space losses. Severity risk assessment should be undertaken. Signs of sepsis, pneumoperitoneum, closed loop obstruction with strangulation warrants an emergency surgery ASAP. Intestinal decompression via the insertion of a nasogastric tube is one of the important mainstay in the preoperative management of obstructed patients. However, the ability of the NGT to decompress will depend on the function or competency of the pyloric sphincter, which when functioning or competent prevents the backflow of the intestinal contents back into the stomach, as manifested by a whitish NGT output. Only an incompetent or a non-functioning pyloric sphincter will allow the NGT tube to work through decompression as manifested by a greenish or bilous NGT output. Right colonic obstruction is characterized by small intestinal dilatation with the rest of the distal colon collapsed and free or of no fecal loading. Assessment of the patient's physiologic and functional status and comorbidities dictates the surgical management option. For hemodynamically stable and good risk patient, a right hemicolectomy with anastomosis is the primary option. For hemodynamically stable but with moderate risk, a right hemicolectomy with ileocolostomy without anastomosis is the better option. In poor risk, hemodynamically unstable patients or with an unresectable tumor only an ileostomy or proximal diversion is the best option. Left colonic obstruction is characterized by large fecal loading with markedly dilated proximal colon, thus with a high risk of ischemia, especially in patients with a competent ileocecal valve. The patient's physiologic and functional status and comorbidities dictates the possible surgical management options. For hemodynamically unstable, poor surgical risk patients, warrants a three-stage operation by doing colostomy only. This allows a fast surgery to relieve the obstruction, and patient will undergo a second stage surgery to resect the tumor once sepsis is resolved and patient is optimized. For moderate risk patients, especially those with significant comorbidities but hemodynamically stable, resection of the tumor with colostomy is the better option. A second operation is done several months to years after for reconstruction of intestinal continuity. For the young, hemodynamically stable patients, good risk patients, an option for a one-stage resection with anastomosis by doing a total or subtotal colectomy or an on-table lavage to remove and clean the fecal-laden proximal colon with resection of the tumor and anastomosis. This is a young adult female with an obstructing sigmoid cancer. Patient is good risk, hemodynamically stable without comorbidities. The proximal colon is markedly dilated with heavy fecal loading. A total colectomy with primary ileorectal anastomosis was done for reconstruction. Thus, patient do not have a stoma. Another one-stage option for a good risk hemodynamically stable patient is the on-table lavage, followed by colectomy with primary anastomosis. A catheter is inserted in the proximal colon, usually at the appendix site after removal of the appendix. This is followed by distal colon flushing with saline or sterile water until the effluent is clear. This is followed by colectomy and primary anastomosis. Thus, a patient has no stoma. Lower gastrointestinal bleeding is defined as bleeding distal to the ligament of Treitz, while massive lower gastrointestinal bleeding is bleeding with a significant blood loss resulting to hypotension, thus fulfilling the definition of a class 3 hemorrhagic shock. However, it is fortunate that majority, around 85% of patients with LGIB would stop spontaneously. Majority of the etiology giving rise to lower gastrointestinal bleeding are colonic pathology, comprising 85% of causes, followed by an upper GI bleeding that is significant enough to transit the GI tract manifested as hematochezia. This comprises 10% of lower gastrointestinal bleeding cases. Small intestinal pathology comprises 5% of lower gastrointestinal bleeding cases. Enumerated here are colonic conditions that will lead to lower gastrointestinal bleeding. First in the list is diverticulosis, contributing more than half of the cases at 55%. Clinical manifestation is characterized as painless bleeding, often with hypotension due to massive bleeding because of the arterial nature of the bleed. Angiodysplasia is often seen among the elderly, characterized as painless bleeding, often without signs of hemodynamic instability. A source of the bleeding is venous in origin. Colon cancer often manifests as occult bleeding, especially if the location is in the right colon. Rarely do we see patients with colon cancer manifesting with severe bleeding. Ulcerative colitis, an inflammatory bowel disease, presents with mild to moderate bleeding and accompanied by diarrhea and systemic signs of chronic illness such as weight loss. Ischemic colitis is often seen among septic admitted patients who suddenly experience diffuse abdominal pain and hematochezia. Because of the low flow state brought about by sepsis, the preferential blood flow is redirected to the most important organs, that is the brain and heart. Thus, the splanchnic organs such as the intestine will have a decreased blood flow, thus can lead to ischemia resulting to abdominal pain and bleeding. Bleeding internal hemorrhoids is often the most common cause of bleeding among patients less than 50 years old. Patients manifest with painless bleeding and characterized as bright red, dripping, or sometimes squirting during defecation. The basic tenets in the management of LGIB are: number 1, clinical assessment and resuscitation; number 2, localization of the bleeding site; and number 3, therapeutic intervention to stop the bleed. To exclude a possible upper GI bleeding, insertion of NGT can be done at the emergency room. However, the accuracy of NGT to rule out upper GI source of bleeding is dependent on the function or competency of the pyloric sphincter that prevents the backflow of small intestinal contents back to the stomach as manifested by a whitish clear output. Only when an incompetent or a non-functioning pyloric sphincter will allow the NGT to rule out upper GI source as manifested by a bilous or yellowish output. Likewise, an anorectal examination with the use of a rigid proctoscope can be performed at the emergency room with the purpose of ruling out anorectal pathologies. The latest guidelines in the management of lower gastrointestinal bleed recommends patients to be categorized either as stable or unstable using the shock index. Shock index of more than 1 is unstable and shock index of less than 1 is stable. Shock index is computed by getting the ratio of heart rate over the systolic blood pressure. A stable shock index of less than 1 means there is less likely to have severe active bleeding. However, an unstable shock index of more than 1 means there is a suspected ongoing active bleeding. The decision for stable patients if they can be safely discharged and to follow up at the outpatient department or to be admitted for monitoring will be guided by the use of a decision tool, the Oakland Score Calculator. We input the 7 information or variables presented here, and it will predict the chances for this patient to be safely discharged or will recommend admission. This algorithm highlights the 3 basic important components in the management of lower gastrointestinal bleed. The latest guideline recommends CT angiography or triphasic CT scan of the abdomen as the first choice of diagnostic imaging to localize the bleeding site. With the availability of CT scan in most private and government hospitals, it is a good choice for clinicians. The advantages and disadvantages of this diagnostic modality is outlined in this slide. A contrast medium is injected intravascularly before CT scanning. Evidence to localize the bleeding site is demonstrated by extravasation of the white contrast medium in the segment of the gastrointestinal tract where the pathology is located. Colonoscopy is also a good option as this is diagnostic and can potentially offer a therapeutic intervention to an identified bleeding site. However, patients needs to be resuscitated prior to the procedure as anesthesia in the form of IV sedation will be given to these patients. Endoscopic intervention should be performed whenever the bleeding site is identified to decrease the chances of rebleeding. The incidence of recurrent bleeding is around 14 to 38% if with no endoscopic intervention. This picture demonstrates a bleeding diverticulosis. Therapeutic intervention can either be the application of a rubber band to the bleeding site, the application of clips to control the bleeding can also be a viable option, the choice of which will depend on the preference of the endoscopist. Mesenteric angiography is one that has great advances and refinements of the technique. This involves cannulating the superior mesenteric artery, the inferior mesenteric artery, or the celiac trunk by an incision through the femoral artery to the aorta, an introduction of the dye to the SMA, IMA, or celiac trunk will localize the bleeding site by demonstrating the extravasation of the contrast medium in the image taken. Once the bleeding site is identified, a super-selective transcatheter embolization using coils is used to plug the vessel responsible for the bleeding area. The top image demonstrates the extravasation of the contrast medium after cannulating the SMA. This is followed by super-selective transcatheter embolization to plug the involved vessel. A post-embolization image shows the absence of the extravasation as previously seen. Nuclear imaging by tagging the RBC with the radioisotope using technetium-99 involves injecting this tagged RBC and place the patient in a nuclear medicine suite under a gamma camera to identify any extravasation of the radio tracer. RBC tagged nuclear imaging is the most sensitive test among the mentioned diagnostic modalities. However, it has the poorest accuracy in localizing the bleeding site. Thus, surgeons often do not rely using this test as a means to direct which part of the intestine needs to be resected or removed. Though a majority of lower gastrointestinal bleeding at 85% stops spontaneously, a few number of patients may end up non-responding to the medical management. Thus, treatment may resort to surgery. Current guidelines recommends that no patients should proceed to surgery unless every effort has been made to localize the bleeding site. The recommended surgery to remove the involved bowel is a segmental resection of the involved segment of the intestine identified by the diagnostic modality as evidenced by its localization. If preoperatively we fail to identify the bleeding site and the patient needs surgery, then a subtotal or total colectomy is the option to take. However, it is associated with a higher mortality rate of around 17 to 25%. Thank you for your kind attention.